topics in the last few weeks, and today we're going to decipher the use of SARS-CoV-2 rapid antigen testing. I think this is very important, as we've seen in the last week or two that we ran out of PCR test kits. I think the presenter will be able to assist and tell us on how to use these. As usual, it's co-organized by Ministry of Health, UB Botswana Harvard Partnership, and Rutgers University. You can join the mailing list by emailing Robert at armumag@yahoo.com. Please do spread the word. The more people we have, or the more healthcare workers we have, the better these sessions become. These sessions are over Zoom. And more importantly, please do mute your microphone during the sessions, as we get a lot of audios at the back and we cannot hear the presenter. You are allowed to ask questions before, which we have received. We'll discuss those a little bit later. But if you want to ask sessions during the presentation, please use the chat function, and we'll give you an opportunity at the end where the moderator will either respond to the chat question, or even the presenter will respond to your questions. The sessions are recorded and made available. Afterwards, I will share how you can access these, and I will also share the slides if you'd like that. And we would like to hear your feedback, please, as to how these sessions can be made better. Give us suggestions on how we can improve. Give us suggestions on topics that you'd like to hear. So this is where you can access all the previous webinars that we've had since last year. And you just go to Project Echo COVID-19 Botswana-Rutgers Partnership, and you should be able to get all these sessions. We recently had webinars on mechanical ventilation, use of CPAP and high flow. I think these are very useful if you haven't gone through these. We do have as well a COVID-19 portal.gov.bw. This is a very, very useful website. It's got different, as you can see, different access points from the data dashboard to the document library. And when you actually click on the document library, you realize that all the guidelines that most people usually ask for are actually available here from 1 up to 18. And these guidelines are actually being updated every 3 months or so, depending on new testing strategies, new management guidelines. So please do go to these, access them, share with patients and other healthcare workers who may need these. But more importantly, share that the COVID-19 portal.gov.bw website. Today's talk is going to be, as I said, on the use of a rapid antigen tests. And we have 2 speakers who are going to initially decipher us in the first talk. We've got Dr. Moyo and Dr. Modisa S. Motswaledi. Modisa is a board-certified medical technologist since 1986. He's got an MSc in medical technology, as well as a PhD in biomedical science. He's also the head school of allied health professions and currently teaching hematology, immunology, and immunohematology. And his research interest is role of blood groups in HIV infection. So given his bio, I think he is the right person to actually lead us on this. Dr. Sikhulile Moyo is a virologist and laboratory director with Botswana Harvard Institute and research associate with the Harvard T.H. Chan School of Public Health. He's also an adjunct senior lecturer with the University of Botswana. He's a researcher and mentor for many, many students and has over 144 publications in peer-reviewed journals. In addition to that, he has a PhD in medical virology. I'm sure a lot of you actually have had chats in one way or the other, whether it's over the phone or through WhatsApp with Dr. Moyo. And I hand over to you 2 learned gentlemen.
Thank you so much, Dr. Palai, and thank you everyone for the opportunity to discuss this hot topic. We are hoping for a robust debate. The science is evolving, but we thought that it was important to to look at some of the considerations in rapid antigen testing that are important as we interpret these results. We know that this is a critical time that some kind of guidelines are required as we expand our testing within all the context that we have. So we hope that in this session, we'll be able to unpack some algorithms and the context of testing and address some questions the best we know how. We don't know it all, but we know that within the panel, there will be also other resources. We know that the antigen tests they are considered a game changer in terms of reaching out in epidemic control. But they are not without caveats, and hence the need for this discussion for us to be able to use them appropriately. We are used to rapid HIV tests for HIV, and these ones, I must say upfront, they are a bit unique in terms of where they are in development. I'm hoping that with Dr. Motswaledi, we'll go through the algorithms. In order for us to achieve a good herd immunity and subsequently have an impact on new cases, it may take up to 3 years. So it's important to identify, isolate, and trace and quarantine as fast as possible. Some people have modeled that for us to be able to reach epidemic control, we must be able to identify cases, and 80% of the cases must at least be notified within 24 hours, and out of those must be isolated, 80% of those within 80 hours, within 24 hours, in order to have the so-called 80-80 in terms of epidemic control. So the testing is crucial, but the widespread testing in Africa is limiting. And if you can look at the numbers, there are 30 million tests conducted in Africa, and with a positivity rate of about 11%. This is about a 23 million tests per million population. And that's about 2.2% of the African population has been tested. So there's a dire need to increase testing. So we have like every case, there's 9 tests conducted. And some say that optimal testing, you need about 10 to 30 tests per case. Coming back home, it's been an outstanding work with all the challenges. I give it up for the lab teams and everyone involved in collecting samples and contact tracing. We've reached 700,000 tests in Botswana. I know that we focus on the challenges, but this has been an amazing achievement led initially by the National Health Lab and all the testing that is now cascaded throughout the country. And we have had about 25,000 cumulative cases. And for every case, we can say that it's about 30 tests if you roughly divide. This is a slide from FIND that tries to compare the costs, the issues around availability of supply. You know that the PCR kits are limited in supply. And as the opening remarks said, that there's been some limitations which I believe are solved. But the antigen tests, on the other hand, if you look at the cost, they are cheaper. And as compared to PCR, that can go, this is even conservative, up to $30, $35 per test, as compared to about $5 between 5 to 8, depending on which kit, some even $9 per test as compared to almost 30, 40. So in terms of accessibility to most of the countries, it looks like the antigen test maybe provide accessibility to testing, the complexity that comes with PCR, and also increasing coverage, especially in remote settings where it remains PCR availability remains a barrier for testing. Turnaround time is also an issue. We need the fastest turnaround time for epidemic control, and 2 to 5 days prevents effective timely response. Like we talked about, the first 80% of the individuals at least identified and reported their positives within 24 hours, as compared to the immediate availability of the PCR test. One recent article said that looked at the modeling and the impact of turnaround time, and clearly a turnaround time of more than 2 days limits the impact of on reducing transmission very much. So requiring that we need to have access to this test as fast as possible. Some of you have seen this graph. It's from January, and you can see that new cases have been increasing and being driven by Southern Africa with more than 3.3 million cases and more than 80,000 deaths. And definitely, I hope I've convinced you that definitely there is a need to change the game in terms of testing, in terms of access to tests. And I've also convinced you that these tests, while they are very good, they come with their own caveats. And so now I want us to zoom through some of the interim guidance documents that have come out from Africa CDC and WHO. And then we will land in with our guidelines that have been developed here in Botswana. So this interim guidance that came out not long ago is really providing access to this test. Maybe let me go back and just talk about what is an antigen test. There are two types of rapid antigen tests. So there is of the rapid diagnostic test for COVID. So it's the antigen test which directly detects the viral antigens, and the antibody test which detects one or more types of antibodies against the virus. So as you can see that the antigen test is looking for the products of replication, and therefore is looking for active disease. There must be a replicating virus for you to be able to get those viral antigens. So the RDTs directly detect these antigens, mostly often the nucleocapsid in the respiratory secretions, which are produced as the virus replicates. Therefore, like the nucleic acid testing, they are very active in detecting active infection. Currently, the available RDTs, they use nasopharyngeal samples or nasal samples. There are some kits coming up, even the ones we are using in Botswana, where the other sample type, the nasal sample type, that is going to be available. And now let's look at this sweet spot for antigen tests. The antigen tests, one of the most important takeaway messages from this presentation is that it identifies cases at high risk of transmission, which is critical for the spread of the epidemic. The left curve here shows what we'll call a normalized viral load and the cycle threshold values. And cycle threshold values are the number of cycles it takes to be able to detect the virus. And you can see that as the cycle threshold values increase, the lower the virus. It means that it takes you a number of more cycles to be able to really quantify or detect the virus, meaning that the virus load is low with higher CT values, as opposed to lower CT values, which are associated with high viral load. And also on my left diagram here, I wanted to show you that the number of cycles, like up to 33, studies have shown that there were no positive cultures that could be cultured with CT values of greater than 33, indicating that most likely active infection is associated with lower CT values. Of course, there are caveats because you are assuming that the sample is not degraded. You're assuming that the sampling was correctly done, because those are some of the caveats that can lead to high CT values. And that is important why we have to interpret the test. The graph on the right shows time on the x-axis and the rise of the viral load going up. So in the few days, maybe 1 to 3 days or 4 days, this is the test area there, even the PCR may not be able to detect. But as you can see, the threshold for PCR is lower than the threshold for the antigen. So you might be able to detect someone with PCR much earlier than you would with the antigen test. This is very important consideration, especially in the early phase of infection. But in this spot here, you can see that both the antigen RDT and the PCR will be able to definitively tell if someone has high viral load. And then as this phase, you start picking up antibodies and you'll be able to tell that someone is positive. And as the viral load goes down, so it means that with time since infection, you can also lower your virus load to such a level where the RDT may not be able to get, but the PCR will still be able. And at some point, you know that the PCR also wins out. This is very important for interpretation. So it means the antigen test is more sensitive when viral load is high, identifies samples with high risk of transmission. So that's the sweet spot that we are looking for. And it's not like an HIV test. So the antigen sensitivity is lower for low concentration of the virus, like we said here, or somewhere here. But also, if you can see the graph here, these are associated with negative cultures and probably very low in the priority of transmission. Of course, this graph shows us that the sensitivity of the rapid antigen is not as high as the PCR, but I hope I've shown you that there is a useful spot if you interpret the results appropriately. There's a nice paper that just came out, just highlights that sometimes the frequency of testing and compared to sensitivity, you find that sensitivity is secondary to the frequency of testing. These are modeling studies showing that if you increase your frequency of testing, even with a slightly lower sensitive test, you'll be able to achieve epidemic control. Time runs out. So now I want us to look at what has been the target product profile that has been put out there by WHO and Africa CDC. The target product profile right now stands at greater than 80% sensitivity and greater than 97% specificity should be used with a broader number of cases and settings for higher performing products. So if you get a test that is high sensitivity, even better. But this is the minimum that has been put out there. And the introduction of tests with higher specificity in settings, particularly with low prevalence, is very important because you want to make sure that you don't have false positives. So if you have high specificity, you know that your negatives are going to be really, truly negative. And so these are the guidelines that are up there. And Africa CDC recommends that these RDTs can be deployed in any settings, though the use cases of greatest impact for epidemic management should be prioritized. And WHO even emphasizes that the greatest area of impact is individuals 5 to 7 days post onset of symptoms, because that's where you get most of the cases. So Africa CDC expanded the use case a little bit. I know that there are a lot of discussions around that area, but that was a bold posture to allow economies to open and in order to catch as many people as possible, as long as you have an algorithm. I have a nice slide from my friend Bill here highlighting some of the performance data that is out there for the kits that we are using in Botswana. You can see for the Pan Bio and the SD biosensor, the sensitivity, depending on studies, ranges between 40 to 85%, depending on study population, of course. And for symptomatic individuals, between 60 to 80%. And it's lowest in asymptomatic individuals. So these are the graphs here on the left side. This is sensitivity. This is specificity. This is Pan Bio. You can see that in asymptomatic individuals, you can see that you have a very high specificity, but low sensitivity. So it means in asymptomatic individuals, you know that a negative is most likely to be negative. But when you have in asymptomatic individuals, you see that you really get individuals that are truly negative. But because the sensitivity is low, you might miss some individuals that are actually have the infection. On the SD biosensor side, you can see that the sensitivity is ranging higher than the Pan Bio. This is some of the data from Switzerland and Germany among individuals with symptoms. You can see that the lower the cycle threshold value that we talked about, you can see less than 7 days, you can see that you have very high sensitivity. If you go to less than 33 cycle threshold, almost 90% sensitivity. If you have less than 25, even higher viral, almost 97% sensitivity, showing that this test can really help to identify individuals with high viral load. But they may miss individuals with low viral load. That's very, very important. Not meaning that those individuals are not important in transmission. They might be, but the impact of high viral load is even more catastrophic. So now in terms of context, before I hand over to my colleague, this is the context that looking at the data that we have, that we need proper interpretation of this test. So that the use case is important. So when you are interpreting this test, you must interpret them in the context. What is the context in which the individual is being tested? Are they symptomatic? Are they a contact of a case? Do they belong to a high risk category versus a low risk category? So it lends us to two strategies of testing. Individuals with high risk in the high risk category and the low risk category. Why? Because in the high risk category, your pre-test probability of testing positive is high, so-called the positive predictive value. And then on the low risk, your PPV is lower. So you may need a different approach in terms of algorithm. So I'm introducing these two strategies, and my colleague will go through the algorithms themselves. So in terms of testing strategy, they are divided into two for the reasons, for the properties of the test that I've just shown you is the best that the world has right now in terms of kits. And of course, this space is developing very fast. So in the testing scenario with individuals with non-risk, or they're exposed, or they are suspected cases, or regions of widespread community transmission, you have asymptomatic contacts, frontline care, healthcare workers. So the location of testing is given there, and these are the target populations, patients who have symptoms or present with high presentation. This lends into the high risk category. So we expect that the test properties here, we are going to pick a lot of positive in this case, and therefore the algorithm will be different from the other case. So in terms of general population screening, where there is no suspected case or confirmed outbreak, this includes general population screening, schools, points of entry, educational institutions, workplaces. So this, you expect a lower prevalence of disease here, and those are the target populations there. So I'm going to hand over to my colleague, Dr. Motswaledi. I'm going to move the slides for you. You take us through the two algorithms addressing the two target populations. Are you there?
All right. Am I audible? I hope I'm audible. Am I audible?
We can hear you.
Okay, lovely, lovely. Okay, so here we have got two algorithms. The first one that we are looking at here is the one that includes that takes care of the high risk group, or where we have a high level of suspicion or reason to investigate. And these are diplomatic cases, frontline workers, and essential workers, contacts of confirmed cases, high risk populations in confirmed outbreaks. And you do the antigen test. If the antigen test is positive, then we report that as positive, and you manage that as positive. That, which means that you initiate appropriate treatment, implement infection and prevention control, and where necessary, do further contact tracing. However, the test may turn out to be negative. And in that case, you have to ask, is there a high degree of suspicion, clinical suspicion, or should we take the test at face value? Now, if the answer is yes to that high degree of clinical suspicion, our algorithm will allowed it to do for further tests to be done. If the answer is yes to the high degree of clinical suspicion, then we still isolate and test, and manage as a positive result. However, because we need to confirm that test, and it is also a general principle that we are applying, then we'll repeat the antigen test, or preferably confirm with a PCR. That is the preferred way to go about it. And if in that case the test comes out to be positive, then it will be treated as a positive, and if it is negative, it will be treated as a negative, and you will have to find what the other causes are for that potential symptoms that were found in the patient. Otherwise, if there was no clinical suspicion and it came out negative, then reported as negative in this group. I think we can go on to the next slide. Yes. Now, some special consideration is that one of them is that a negative result may not imply that there is no infection, as they can still be in the pre-infection stage, as you saw that in the initial 3 or so days of the infection, that the antigen may not be detected, or the kits may not be able to detect the presence of the antigen. So you still maintain the high degree of clinical suspicion, isolate, especially in the presence of anything suggesting that the patient may be infected. For healthcare workers, obviously you screen today, tomorrow you may get infection, so a regular testing is recommended, as Dr. Moyo just pointed out, that frequency may be more important than sensitivity of the test. So regular screening is recommended, particularly where community spread is detectable, because these healthcare workers are in constant contact with the community. In areas with limited to no suspected or confirmed outbreaks, a positive result should be interpreted with caution due to the low likelihood of positive result in that population. So we should retest with RDT antigen, and then confirm where possible with okay, thank you. That's fine. We can move on to the next one. The one where you have got really just general screening, where you have got institutions like schools, workplaces, a negative result may be reported as a negative result. Okay, and there's no reason here, you are just screening, so we report it as negative. But where it is positive, again, there you isolate and manage as a positive. And because we also have got the policy, and WHO recommends that we do not make a positive test on the basis of one test. So it is always good to confirm with PCR, and then you have got a more, if it is still negative, if it turns out to be negative with PCR, then it should be reported as a negative and should be considered to have been a false positive result. If it is positive, it then confirms. But it is possible to get these discordant results between the antigen and the PCR in non-symptomatic individuals.
Thank you,
Right.
thank you, Doc. Just to confirm as well, the National Health Lab has been working with the Gaborone DHMT, doing a lot of validation of this, and the results are not yet shared, but one of the most important results that we realized that almost 100% of symptomatic individuals who were positive with antigen tests, they were also positive with PCR.
That's correct.
That was like a fantastic result among symptomatic individuals. But among asymptomatic individuals, we see some individuals either side, which shows that it's important to have an algorithm. Other special considerations before I ask Modiri to talk to some issues is screening in semi-closed areas where maybe social distancing is challenging, maybe mining areas, or maybe areas of critical economic activity. And also WHO recommends that for mitigation strategies, it recommends that at a certain threshold of about 5% or as low as 5%, this is a trigger for mitigation strategies. Of course, quality assurance is important. This is where training is going to be emphasized by the next presenters. Training is important. Making sure that we use the correct tools is important. It's still an epidemic. We are tracking data, filling in the correct information, whether the patient was asymptomatic or not, the reason for testing, whether they're at point of care or not. As you can see, that these things are very important. There's a training package that has been developed, is out there. Data management is very important. And continuous learning, as you can see, this is an evolving field. I'm going to skip this slide for the sake of time, but this slide was just trying to emphasize the importance of when you have low prevalence, there are higher probability of false positives. And that's very important. But these kits have very, very high specificity. And so in a setting where you have higher probability of testing positive, so we are able to distinguish the negatives truly very well. But this will be available. And also this was interpreting the two scenarios where you have probably a higher rate of prevalence and a lower prevalence, and just playing around with specificity and sensitivity and showing the number of cases you might miss in the two different scenarios. But in summary, it was meant to show that if the sensitivity goes down, you are likely to get false negatives, and the impact is potential transmissions. As well as if the specificity is going down, you might get increase in false positive, and also you might have trigger of false outbreaks. Hence, the algorithm is allowing us to do some confirmations for low risk category, because you get a positive there, you are not sure whether it's a true positive. There it needs to be confirmed. But in a high risk setting, you get a positive, and it's likely to be positive, and our local data is also confirming that. So these tests are very simple, but training is very important. And just for a few seconds, just for you to see how this test is conducted, you need to adhere to collection guidelines in terms of safety, in terms of making sure you have the proper gear for collection, and then you have to make sure that you have the right tools there. They are in the package, And so this is the buffer that is used. You put in the appropriate amounts of the buffer up to the line there, and you make sure that the rack which is provided, you put in the rack that is provided there. And of course, we can not overemphasize the correct collection. Don't put in the swab and immediately run out. We need those secretions. So it's required that you have at least those 3 seconds for and the turning around. That is very important. And after that, of course, you put this there. There's a liquid inside that lyses the virus. Actually, it's a very good one for safety. It does lysis, renders it less infectious. And then, of course, you don't open the tube again, and then you enter the drops that are required there. For those who have attended training, they've had hands-on of these technologies. And the importance of waste management and adhering to the time for the test, 15 minutes to 20 minutes, not more than that, not less than that. And the reading of results, the first one shows that the control worked and the test is positive. The second one, the control worked and the test was negative, and the other one was invalid. So that's the other test we are using. And the other test we are using is the principle is almost similar, and also emphasizes the issues around safety, the face masks, the goggles, all these things that you need. Although you don't need a biosafety cabinet, you need to make sure that you are in an environment that is away from papers. You have your paper towels. You try to prevent any environmental contamination as you do the test as well. So these are recommended. Okay, so the storage conditions, as you can see, are very user-friendly. And that's the swab, and the importance of making sure that we have a good collection. So you need to use people that are trained for collecting. So it means that not everybody can just test without the training, especially for collection, which is very, very important. The kits have expiry dates. You need to check the kits. The log sheet that my colleagues will talk about, you have to record this information for every test batch that we are doing, so that at least we know if we identify problems with any batch, we'll be able to go back to the manufacturer. So that's the other test that we use. Okay. For the sake of time, I'm going to stop it there because the principles are just the same. For those who attend the training, you get all the videos and all the slides. So for the sake of time, I'll end that video there and just point out a few things about safety. There is that guideline there. Of course, although the BAC is not required, you need to make sure that you are in an area well ventilated, free from clutter. You do a risk assessment to make sure that the environment that you're working in is safe, and waste management. So just to conclude, these antigen tests are likely to give us an impact. And as we have seen that this is the best that the world has produced so far, there are some caveats, hence the necessity for algorithms, and that the accuracy of results depends on the context. That's very important. And that there's training, quality assurance, and data management. I think I will stop there to allow our colleagues to come in, so that next, I know that there's a lot of discussions that may come in. Sorry if we have passed, but we want to allow for the next presenters to be able to share their work. We want to acknowledge the CDC guidelines were developed with a number of people from different organizations I was fortunate to participate in that. And also external reviewers making sure that at least they communicate the intentions of the guidelines. And we want to appreciate locally Bill for his insights and some of the slides, find for some of the contributions, and the heroic work from the National Health Lab in really evaluating these kits under very difficult conditions. And we give it up to the team that is in the field. And without DHMTs, we wouldn't be talking about data that we are talking about in Princess Marina Hospital. So I'll stop there. Modiri.
Thank you. Thank you so much, Dr. Moyo, for that insightful talk. I'm sure you can imagine there'll be lots of burning questions around this topic that is ever much so loved during this time of the pandemic. Just continuing that heroic statements that you made. At this point, I would like to introduce our colleagues from the National Health Lab in Princess Marina, Mr. Modiri Tau and Mr. Kagiso Linchwe. Mr. Modiri Tau has got a master's in biomedical, he's a medical laboratory scientist, and he's got a master's in biomedical science, and he's been leading the pandemic response on the National Health Lab side, and we really thank his efforts. While Mr. Kagiso Linchwe is based in Princess Marina, he's got a BSc in biomedical science, and he's been leading the pandemic response from that respective position. They are here, as Dr. Moyo said, to talk to us about the general training and consideration with regard to use of this tool, which is very, very important, of course. Over to you, gentlemen.
Good afternoon, sir, and then good afternoon to everyone. Modiri Tau here. And good evening, everyone. Kagiso Linchwe here. Okay, I've shared my screen. Are you able to see the screen there? Hello?
Yes, yes,
we can.
Okay. Thank you very much. First and foremost, I would like to thank our colleagues, Dr. Moyo and Dr. Motswaledi, for the presentation, the lovely presentation that they've just given us. We are quickly going to go over the briefly talk about the trainings, and then also on data management, and then the tools that we use for antigen testing in Botswana. All right. Okay. So now in our rolling out of antigen testing in Botswana, we focus on 3 key activities. The first one was training, and those are the activities that our presentation is going to be focused around. And then the other one is data management and data capturing tools, and then continuous support and mentoring for those that have been trained. Now training, as it's already been mentioned before, it is key that testing is done by trained personnel, so as you are able to deliver quality results. So we started antigen training in December, and then there were training in December 2020, and then we divided our training into 2 groups. So what we did, we had started off with a trainer of trainers training, and then it was followed by a testers training. Now the idea of a trainer of trainers, it was to bring in quickly a group of people that are already experienced in testing. The group that we focus on here were the trainer of trainers of HIV rapid testing. And then that group was already experienced in training, group was already experienced in offering support with regard to training, and then they had extensive experience in rolling out testing around the country, and then they were coming from the different districts. So that training, we call them to a central location. We called it a centralized training, where we had all of them coming from the different DHMTs from the country. Now, we started the trainings, and then by the 21st of December, we had concluded the train of trainers training. And then what we also did, because at the time we had to move really quickly, we were fortunate because ASLM had already trained a very lovely training package, which we adopted for the training. The training package is quite extensive. It had talked about all the different technologies that are there for antigen testing, and then it also had a module for assessment, which we use to assess our train of trainers. And then after we're done with our TOTs, they went back to the different facilities where they were mandated with ensuring that everyone at that district that is going to be involved in testing is tested, is trained. And then the training was to also focus on issues of quality, so that it ensures that, we ensure that we produce quality test results that are actually the same as those that you get from the lab. And then this cohort, like I mentioned, that they are also trained before, and then they've been dealing with these issues. They will also continuously be offering mentoring and support at all those sites. So as we speak, training had started from around December, and then a lot of testing is happening at the district, and then that is the training that has been done by our trainer of trainers. And then we still have some training that is ongoing. Because what happened, we started off with about Panbio test kit, and then we then brought in a different test kit. And then for that, because there are some slight differences in the test kit, we have to also do some refresher training as well. So that is training that is ongoing, and the TOTs are heavily involved in that. Now I'm going to move into the data management. So what we've noticed is that with antigen testing, because of its nature to give results within a short time, and thereby being conducted by different people at different sites at the same time, we got quite a lot of data coming in within a very short time compared to when testing is done at the centralized facility. So for that, we still need to put the same measures in place with regard to collection of statistics, with regard to reporting all the data that is concerned with SARS-CoV-2 testing. So for this, in terms of data management, daily statistics reports of received and tested samples are to be sent to the National Health Laboratory for collation and reporting to the ministry, as well as COVID Presidential Task Force, the same as has been happening with the PCR testing. Now, all positives should be reported to the district health management team and NHL as soon as they are known. We should also, at the same time, ensure the request intervention so that contact tracing can, all issues or measures to do with contact tracing can be effected. The contacts of the key officers responsible for compiling results will be made available. Facilities are expected to work with respective DHMTs and designated laboratories in implementing the antigen RTD testing strategy. There was a communication that has already been sent out that shares the guidelines to follow with regard to antigen testing. And then the facilities are actually urged to read those testing guidelines and then adhere to those. At the same time, as a way of ensuring quality, facilities should participate in inter-laboratory comparison or quality assurance, or EQA. Now I'll move on to data capturing tools. So what we've noticed, and then what we discussed together with the colleagues, and then which is also very key to the ministry, is all the data involving SARS-CoV-2 testing should be reported centrally, collated and reported centrally. So the ministry has been working on capturing that data electronically, and then while we are still working on that, we are also making sure that which we are unable to capture electronically, we capture it manually. So for electronically, the ministry has got IPMS and then DHIS2 as the two platforms that we can use to capture this antigen data. So the challenge with IPMS, although it's been around for a long time, it is not widely available, especially at the different testing points that are going to be at the different facilities there. IPMS requires a stable connection, a GDN connection, which is not readily available everywhere. So, however, the bioinformatics department had, working with NHL, they've already they've worked on IPMS and then made sure that make sure that capturing antigen data on IPMS is going to be possible from the 9th of February. So what they are also doing is that they will go on and follow with the necessary trainings at all the facilities that have got access to IPMS, so that they are able to capture that antigen data on IPMS. And then we also have DHIS2, which is web-based. So bioinformatics will ensure that all points that are conducting antigen testing have access to DHIS, so that data is straight away captured on the system, and so that we don't get to lose this data. So for that, the Ministry through the Bioinformatics Department will provide devices that are going to be used to capture this data. That is in the form of tablets for capturing, and then printers that will also facilitate with printing results where necessary. And then also what they're working on is to ensure that results will be shared electronically, because there may be points where access to a printer might not be possible. Sharing results electronically in the form of SMSs would also ensure that you have quick turnaround time, and also you save on some resources as well. But however, as it is right now, while we're waiting for the system to be put in place, data is still captured manually. There is an antigen RDT specimen requisition and reporting form that is in place, that has been developed. It's been implemented. It's a control document. It's been shared with all antigen testing facilities. That is the one that is being used. And then at the same time, we have a specimen logbook and register. Now, these registers are the ones that we use to capture all the antigen data on, such that we are able to follow up or track the antigen test kit that was being used. We're able to follow up who has been conducting the test. We're able to follow up whether the antigen test kit that was used is still valid, not expired or anything like that. It has all that information that we can also compile from it, and then compile the number of tests that have been performed per facility, hence being able to work the work that has been done out there. It is currently the best that we have. It is labor intensive. There's potential of losing some data, but at the moment, it is what we are having. And then we are also, we urge everyone, the facilities out there, to please use these logbooks. We've shared them with all the facilities, so that we don't in any way lose any data. This is the antigen logbook register, just so as you get to appreciate it. like I indicated, it captures a lot of, the fields capture a lot of information about the patient. You've got the patient name, the ID there. You also capture the contact information, not the patient, of the client, a whole lot of information about the client, so that if we were to go back to it and then we look for some data regarding the client, we should be able to get it from there. That is while we are wait for the our electronic systems to be in place. Also mentioned continuous site support and mentoring. So with the presence of the team of trainers, we have at our different DHMT support that is given to our testers. The support is in the form of mentoring and ensuring that they continue doing the work and producing quality test results. Also have support in the form of ensuring that the antigen testing commodities are available. And then what they also do, they form as a link between us at NHL and the testers on the ground, right? And then while we're there, NHL also continue to provide overall monitoring and support to all the district with regard to antigen testing. This is all what we wanted to share with you with regard to training, and then the data management and the tool that we're using to capture the data for antigen testing. Thank you. Are we?
Thank you very much for that a brilliant presentation, gentlemen, on training. I'm looking at the time and we're already past 5. I think I'm going to go straight into questions, and I'm going to actually address a few, sort of combine a few that are in the chat box. And that one is from Dr. Malone and the other is from Dr. Moloi. And the concerns are that, have we in any way engaged the private sector in the training of the rapid antigen testing? And is the NHL actually thinking about giving these test kits to the private institutions, medical aid going to assisting patients who are covered by the medical aid? Hello.
Hello.
Yes. So I think we can maybe start off with Dr. Moloi, which maybe we cover if the private institutions, have we identified people that, or we made a plan to get them trained? Obviously, they're part of the response as well.
Okay. Just before I go on to the training, the one thing that I did not mention when I was talking about the data management was that DHIS2 is going to be available to the private sector from the different points where they will be conducting their activities, so that as they test, the data is captured on real time, so that it is not in any way lost. That's one. We have so far not been training the private sector, and then that is an area that is still to be discussed and then agreed upon. But the training that has been happening now has been focusing on the government facilities.
Okay, no, I think that's a fair game. I think there obviously has to be discussions between the NHL and representatives in the private sector. I think it's very important. I think the other one was, which is I feel is also very important to the control of the pandemic, is whether NHL is going to consider giving private institutions these testing kits, and how we get medical aid actually on board to actually cover patients that are in private institutions for these tests. And that might be a question that maybe we may not be able to answer on this platform.
Yes, that's right. I may not be able to answer that question, but if there are some, Moyo, Dr. Motswaledi, if they are there, need help with that. But for now, I may not be able to answer that one. Thank you.
I think that's a good point for policy discussion. Of course, we can throw it to the relevant team, the relevant folks.
No, I agree, Dr. Moyo. I think the discussions probably have to start sooner rather than later for the sake of patients, and given the trajectory that our pandemic and the number of deaths that we are getting so far. There are many questions that have been sent. I'm sorry I have to rush through, but however, most Dr. Moyo has actually covered in terms of sensitivity and specificity of these tests, as well as the algorithm of the test. We will share the presentation. One question that I thought was interesting, Dr. Moyo and colleagues, is what is the science behind actually getting a false positive rapid antigen test? I think it was asked by Dr. Tia earlier.
The science behind it.
So
factors that come in.
Yes. And so you were saying, sorry, Dr. Moyo.
Okay.
Explain the science of the false positive antigen lateral flow test. Yes. Sorry about that. Yeah. Go ahead, Dr. Moyo.
There are many reasons for a false positive test. As you can see that these tests are not 100% or 99% specific. They are around 97%. So you still have a probability that you may have a false positive because of the characteristic of the kit itself. It may miss because maybe there's cross reactivity that you might find within the sample. There's also possibility of contamination can lead to a false positive case. So I think those are the scientific rationales around that. But it's an interplay between sensitivity and specificity, most importantly, and of course that the possibility of cross-reactivity.
I totally agree, and I would like to add to that, Dr. Moyo, that with this lateral flow test, you're also having an antigen-antibody reaction that forms a complex that is to be detected. And you are dealing with coronavirus, and it is not the only one in the world. So in some way, there might be some portions of a protein that may be shared between the two, and that may, or any other, molecules that may react with the antigen and be captured and do provide a false positive. But as you would have seen, that in terms of that percentage, it's a very small fraction. Thank you.
All right. I'm just browsing through the questions, Dr. Moyo. Just give me a bit and see which ones I believe were not covered. I think we did speak about medical aids. The availability was covered, and the training. The sensitivity was covered as well. And then there's one here: which variants are so far have been identified in Botswana, and do we have any new variants locally?
That's a good question. We are hoping that this data will be shared in another webinar. But preliminary, yes, we've identified variants of concern. There are three major lineages that you worry about. But the lineage that we've identified is the B.1.351, which has the variant 501 variant 2. You know, the variant 1 of 51001 position of the spike was the UK one. The variant 2 is first identified in South Africa. Yes, we confirm among specimens sequenced at NHL and Bitri in December, the variants of concern were identified. Also at the Botswana-Harvard with sequence recently, we've also identified and confirmed that we have variants of concern, the variant that is circulating in South Africa. The extent to which these variants are circulating is still a question mark, and there's more work that we are doing collaborating with these two labs to answer these questions. And also looking at severity of disease, disease progression, is it being driven by the variant, and also transmission clusters where you find that within a short space of time, there's so many people infected. So those questions we hope that the team and collaborating teams will be able to answer. Thank you.
All right, I think we won't have, unfortunately, we won't have time. We can go on and on and on and on and talk about this topic, Dr. Moyo, Mr. Tau and team. But
there's one that,
okay.
There's one that if you don't mind. I think it's important to interpret these kits in context. There's a question someone was saying, are these kits useful for contact tracing? Since maybe in the early phase when we discussed that graph, you may miss some individuals. It's important to analyze in context a high degree of suspicion. And because someone is getting into quarantine, you can repeat the antigen test, and definitely if you have a reasonable suspicion, you should be able to catch that individual. Is very important, because you might have, but the individuals in the earlier phase, that in those 3 to 5 days, the fraction is very, very, very low. That while it's concerning, I wouldn't really worry much about. But other people, they propose that once you're doing contact tracing and someone is negative, maybe test them with a rapid after 3 to 5 days. That's another approach in a public health approach. Thank you.
Okay, thanks again, Dr. Moyo. Thank you for the participants, for your questions. Please do continue to give us feedback about these sessions. Remember, they will be shared on YouTube, including the slides. So please do not worry. You can go through this during your own time. At this point, I'd like to hand over to Dr. Gaolathe. I know she had technical difficulties. I don't know if she's on. Dr. G?
Yes, thank you, Tommy. Thank you, Dr. Moyo, Motswaledi, Modiri, for a wonderful presentation. I know we would have loved to ask more questions, but we may come back to you based on the demand. I think with that, we will also plan on the next webinars. In our list, we have radiology by Dr. Tashima Boreke. We're hoping he comes on board Thursday. And we will revert back to Thursday only meetings and